Good afternoon. I'm Maha Wahid, brand manager at Advia Pharmaceuticals, wishing you all and your families to be safe and secure during these hard and tough times of COVID-19 outbreak. And for the sake of your family and your safety, and as we commit ourselves to enrich the medical community through different CME programs, we are hosting this precious discussion through today's webinar. And before we start, allow me to introduce my company in a few minutes. Actually, Advia has a long-standing presence in the pharmaceutical market since 1984, with an objective of delivering cost-effective and safe medication to all Egyptian patients, and guarantee its availability all over Egypt and other 36 foreign countries of which Advia export its medications to. We feel that we are your clinic's partners. Whatever the problem is, we have the solution. Actually, we have the optimum solution. Advia has a huge portfolio in many different therapeutic areas: cardiovascular, anti-infectives, central nervous system, GIT, musculoskeletal, respiratory system, urogenital disorders, dermatological disorders, gynecological disorders. And finally, our big and huge pediatric portfolio. Our pediatric portfolio in Advia tackling the patient-centric approach by putting the patient in the center and offers more than 8 products to the pedia sector, such as, and you are mainly familiar with most of our products, such as Statucast, as a Montelukast, adding on in asthma management, Trustenal, nitazoxanide, an antidiarrheal, Winsif, Cefepime, as fourth-generation cephalosporin for lower respiratory tract infections, Dinar, Cifdinir, as a third-generation cephalosporin, upper respiratory tract infection and otitis media, Yoripan, oxybutynin, treating overactive bladder in children, Spasmo-free, timonium methyl sulfate, as an antispasmodic and colics in children, Adviflam suppository, a diclofenac potassium as an antipyretic, and finally our Densit as ondansetron. Densit is the first anti-emetic drug in Egypt because of your trust and because of your support all over the journey. As we always said, when it comes to vomiting, it's Densit. Wishing to continue the journey together all over the way. And thank you very much for listening. And now, very warm welcome to Professor Hania, Professor and Chair of Pediatric Department and the Medical University of Warsaw. Also, it's the member and of the Committee of Ispagan. Our Professor Mustafa Al-Hodhod, Professor of Pediatric Gastroenterology and the Head of Pediatric Department at Ain Shams University. Also, special thanks and welcome Professor Wael Bahbah, our today's moderator and the President of Egyptian Academy of Pediatric. Welcome, Dr. Wael Bahbah.
مساء الخير. مساء الخير دكتورة مها. مساء الخير عليكم جميعا. بسم الله الرحمن الرحيم. أحبائي وزملائي أطباء الأطفال في مصر والعالم العربي. سلام الله عليكم ورحمته وبركاته. بداية ننعي بالغ الحزن والأسى شهداءنا الأبرار سواء على الجبهة وهم شهداء بئر العبد جنودنا البواسل الذين انتقلوا إلى رحاب ربهم أمس في سيناء، وكذلك شهداء الجيش الأبيض جنودنا دكتور ممدوح السيد مدير إسعاف سوهاج، والأستاذ الدكتور هشام الساكت أستاذ جراحة الأطفال ووكيل كلية الطب لشؤون المجتمع وخدمة البيئة بجامعة القاهرة، اللذان انتقلا إلى رحاب ربهما اليوم بعد صراع مرير مع فيروس الكورونا. اللهم احشرهم جميعا مع النبيين والصديقين والشهداء والصالحين، حسن أولئك رفيقا. وأسألكم جميعا الدعاء لهم وقراءة الفاتحة. آمين آمين يا رب العالمين. First, I'd like to thank all pediatricians, all my colleagues for attending this webinar. Then, special thanks to Advia Pharmaceutical Company, Dr. Maha, and all team sponsoring this highly scientific meeting. Also, special thanks to all team Egyptian Scientific Society of Pediatric and Neonatology and the Egyptian Academy of Pediatric and for Quartz Event Solution for their great effort in the scientific technical organization of this webinar. And now it is my honor to be a moderator for the second time in 1 week for this great webinar that brings together two figures in the field of pediatrics and the pediatric gastroenterology and nutrition over the world, Professor Hania Chaufiska and Professor Mustafa Al-Hudhud. Today is a special day. We will go through a panel discussion with a clinical dialogue between them, not a two separate presentation. Let me first introduce our great professor. First, Professor Hania Chaufiski, professor and chair of Department of Pediatric at Medical University of Warsaw. He served as editor-in-chief of the Journal of Pediatric Gastroenterology and Nutrition. Professor Chaufiski served as a member counseling General Secretary of SPGAN. Now, she is a board of director in the International Scientific Association and Probiotic. And our second figure is the Professor Mustafa Al-Hudhud, Professor of Gastroenterology and the head of Pediatric Department, Ain Shams University. Professor Hania, Professor Hudhud, I am very happy to for the second time in 1 week.
Good evening. It's my pleasure. Already for the second time.
Yes. Okay. Thank you very much.
At least virtually in Egypt. Thanks a lot. Thanks for the invitation.
Thank you, Professor Hudhud.
Thank you, Dr. Wael.
And now the floor for us. Yes. The floor for you.
Yes.
For me. Yes. You.
Thank you.
Okay. New options, request. Okay.
Good night, my dear colleagues and friends. Before starting this activity, I should direct all our efforts and all our hearts to souls of brave men who faced the Black terrorism and to souls of healthcare professionals facing Black COVID-19. But in spite of all these obstacles, great nations, and Egypt is one of, survive with obstacles. Functional GI disorders, a dialogue between Professor Hania Chaufiska and myself. Professor Hania, let us start with clinical scenarios, please.
Thank you very much. Indeed, we can start with clinical scenarios. So let's start with the first one. Okay. Oh, sorry. Sorry. Oh, goes too quickly.
Yes.
But I will learn.
This is okay.
With the first clinical scenario, let's try to think, what do the following children have in common? A 12-month-old girl with hard pellet-like stools, a 3-year-old girl with frequent complaints of dysuria and hard stools, an 8-year-old boy with a weekly stool that is large enough to clog a toilet. Finally, a 12-year-old boy with daily loose stools in his underpants. Think, What do the following children have in common? Okay, let's think about clinical scenario number 2. Oops, not easy. And clinical scenario number 2 is, no, it should go back.
Yes, it's good.
No, we do have some problems.
Yes.
I don't know. Okay, no, you cannot change it. It's only me who will change it.
Yes.
Because
Yes.
if you change it, then I will have problems.
Yes.
Okay, so I presented you some of the clinical scenario. Now it's another clinical scenario. An 8-year-old boy who presents with his 3rd episodes of abdominal pain in 3 months. He has gripping abdominal pains centered on the umbilicus, flatulence. He has repeated visits to the toilet with loose stool. He has defecation which seems to ease the pain for a short period. He went through a similar phase 6 months ago. All his laboratory tests are normal, and as you can see, there was a lot of them done. He gains weight satisfactory, and his mother wants him to have a scan as something must be wrong. And these episodes are affecting his school attendance and causing stress at home. So think, what could be your diagnosis? And with that, let us move to the next scenario. And the next scenario, it's only me who can change it. If
Yes.
2 of us change it, we will have problems. Okay, I'm sorry, it doesn't work so well as we thought.
Yes. No problem.
Okay. You have problems.
Yes.
No, and the clinical scenario number 3. And clinical scenario number 3 is a 6-week-old baby brought to the emergency department late in the evening with a chief complaint of extreme fussiness. His parent thinks that he has abdominal pain as he's gassy and pulls his legs up as if he's trying to stool. Tonight's episode has lasted for 4 hours with intractable crying, and the parents have tried feeding, a pacifier, rocking, burping, changing the diaper. Nothing helps. He is currently fed a standard cow's milk formula without vomiting or diarrhea, and further questioning reveals that this is his 4th episode in a row, and this has happened on a daily basis, usually in the evening, but the baby usually cries for about 2 or 3 hours. On physical exam, everything is normal. And again, think of your diagnosis. And the question is, what did these children have in common? And I hope very much that all of you thought about functional gastrointestinal disorders.
Then the question will be, what are functional gastrointestinal disorders?
Okay, so now let me explain what are functional gastrointestinal disorders. Currently, we are using to describe them so-called raw 4 criteria. And functional gastrointestinal disorders, according to those criteria, are variable combinations of chronic or recurrent gastrointestinal signs and symptoms without obvious structural or biochemical alterations. And what is important is that if you look at the raw 4 criteria, you will see that they are called functional gastrointestinal disorders, but they are also called disorders of gut-brain interaction, which means that there is bidirectional connection between gut and brain. Very important. So even in the name, it shows that there are disorders of gut-brain interactions. And they are also divided into two major groups, those which apply to neonates and toddlers, and those which are more common in child and adolescents, even if some of those will be overlapping. And here you have
Yes. The question is, are they common or all are common? What is the prevalence of these pediatric functional GI disorders?
Okay, this is an important question, and I will try to answer it by showing data, and they were published last or 2 years ago in Journal of Pediatrics on the prevalence of pediatric functional gastrointestinal disorders utilizing the ROM4 criteria. And in a moment, I will show you the data with ROM3 criteria. So first, the more recent data using ROM4 criteria. Results based on the ROM4 criteria are showing that about 25% of infants and toddlers aged 0 to 3 years are suffering from functional gastrointestinal disorders, and also 25% of children and adolescents aged 4 to 18 years suffer from functional gastrointestinal disorders. So 1 in 4 children will have some kind of functional gastrointestinal disorder. Now, what are the most common in this study, functional gastrointestinal disorders? These were infant regurgitation and functional constipation, both among toddlers and children and adolescents. So these were the data as according to the ROM4 criteria. But we also have another study which was published earlier, and here are the percentages of subject meeting ROM3 criteria, so the one which we were using previously. And if you look at those data, you will see that again, the number are quite similar. For example, on generally speaking, it's about 27%. 25 previously, 27 here. And what is also important that this study show that functional gastrointestinal disorder contribute to lower quality of life and increased medical consultation. So it's quite prevalent. And in addition, there are some problems related to this. And my question to you, Professor Mostafa, is what is an Egyptian experience with functional gastrointestinal disorders?
Actually, in one of the series, we assessed in the neonates and toddlers, and we found that almost 2/3 are having functional GI disorders, and 1/4 was organic, 10% only were of the mixed type.
Mm-hmm. So I think that we may summarize this first part of our presentation by saying that functional gastrointestinal disorders are common worldwide and cover a wide range of disorders attributed to the gastrointestinal tract that cannot be explained by structural or biochemical abnormalities. Now,
focus today on neonates and toddlers, Professor Hania.
Okay, perfect.
And this is classified in ROM4 under letter G. And they are 7 disorders, including infant regurgitation, infant rumination syndrome, cyclic vomiting syndrome, infant colic, functional diarrhea, infant dyschezia, and functional constipation.
Great. So we will focus on all of them and we will discuss each one of them. Perfect.
Yes. And what are the most common met pathologies of these in your practice, Professor Hania?
Okay, I will show you again what are the data. And the data are, and they are coming from a study that we have done where we were looking at various functional gastrointestinal disorders and we were looking at the literature, but it very much reflects what we can see in our practice. So you can see regurgitation, it's about 30%, infantile colic, it's about 20%, and constipation, it's about 15%. But what is important that very often you will not make a diagnosis of regurgitation meeting round 3 criteria. You may just have speeding and feeding issues, not infantile colic meeting round 4 criteria, but crying and sleeping problems. And with the constipation, exactly the same. It does not necessarily mean that you have a child meeting around 4 criteria, but it will be hard stools and straining. And there is another slide which I think is important, which shows what are the age distribution. So we already discussed that for infants, it's infant regurgitation, colic, and functional constipation. And please have a look at the functional constipation. This is one of those diseases that may occur at any age, starting very early until, as we know, to adulthood. And another one which occurs quite often also, it's not so prevalent, of course, but cycling vomiting syndrome. It overlaps infants, toddlers, but also older age. So I think it's important, the prevalence, but also the age when it may occur. Okay, but what is an Egyptian experience? I know that you do have some studies on that.
Okay, thank you. And in this pie chart, you can see that the major 3 diseases, which are regurgitation, infant colic, and constipation, represent the majority of presentation of functional GI disorders. It's clear here that the more common in Egypt is the more common all over the world. However, numbers are slightly more. And I think because of overlap between different presentations of these disorders that can occur together, this may raise the numbers a little bit than the international numbers.
Excellent.
And let us start
so let us start with
infant regurgitation, yes. What are the criteria to define infant regurgitation, Professor Hania?
Okay. So let us go to the infant regurgitation according to round 4 criteria. So first of all, what is the definition of infant regurgitation? It's the passage of reflux contents into the pharynx or mouth or from the mouth. And it's often referred as gastroesophageal reflux to be differentiated from gastroesophageal reflux disease. Here we are just speaking about infant regurgitation, gastroesophageal reflux. And the diagnostic criteria, according to round 4 criteria, are that it must include both of the following in the otherwise healthy infants, and the age is important, 3 weeks to 12 months. Regurgitation 2 or more times per day for 3 or more weeks. No retching, no hematemesis, no aspiration, no apnea, no failure to strive, no feeding or swallowing difficulties or abnormal posturing. This is very important because these are so-called red flags. If we do have any of those, we are not thinking about just infant regurgitation, the simple one, but we are starting to thinking about some organic disease. So this is important.
And actually, this is the same repetition of the previous slide by Professor Hania. And here I want to stress one of the practical points of view in which they depend on the diagnosis of regurgitation according to the amount, but you should strictly adhere to the definitions of the things as given by Professor Hania, and again, learn by heart this list of red flags that will take you away from the diagnosis of infant regurgitation. Yes.
Excellent. So there was no agreement between 2 of us. Excellent. Let's move on.
After this definition, do you think that it is a common situation in your practice?
Well, again, I will show you the slide which I already showed you, because as you can see, and this is exactly what we are saying in our setting, regurgitation is very common, about 30%. But again, I want to call your attention that it might be very often just speeding and feeding issue, not exactly meeting the criteria, the round 4 criteria. But round 4 criteria are very important for any kind of research that we are doing, because then we can compare the results from one study with another study. This is a study which I already showed you from published in Journal of Pediatrics, and you can see infant regurgitations 25%. So very similar to what I have just showed you. And again, I have a question to you. What is an Egyptian experience with regurgitation?
Okay, and if we talk the newborns and early infancy in the first 6 months of life, at least 2/3 will have this regurgitation, whether fulfilling the criteria of Rome 4 or just spitting and not fulfilling the criteria. And it was previously thought that regurgitation will finish by the age of 6 months, which was changed later in Rome 4 to 12. And here you can find that minority of infants may have some regurgitation after the age of 1 year, and this may be the explanation of why they raised the age limit to 12 months.
But it's important again to stress that this age is very important, not earlier than 3 weeks and not after 12 months. So it's important, and it's clearly stated in the Rome criteria. Excellent.
What treatment modalities you can use to this category, Professor Hania?
Okay, and I will go again to the recommendation. Now I will go to the recommendations which are developed by the society, which is so close to my heart, ESPGHAN, European Society for Pediatric Gastroenterology, Hepatology and Nutrition, and together with, it was developed together with our North American colleagues, North American Society for Pediatric Gastroenterology and Nutrition. This was an update which was published in 2018, and please note that most recommendations were supported by expert opinion rather than new research of high quality. It means that we are still lacking high quality research to make our recommendations. But let me just summarize some of these recommendations. And first of all, there's an important statement, the gastroesophageal reflux, which is, as a matter of fact, infant regurgitation. It's more common than gastroesophageal reflux disease. Most infants and children who exhibit symptoms of reflux, such as regurgitation that we are discussing, vomiting or discomfort, have uncomplicated reflux rather than gastroesophageal reflux disease. This is an important statement. The other one, over-testing. Despite this, the numbers of infants and children who receive treatment with acid suppression, I will come in a moment to it, undergo non-invasive or invasive testing is much larger than what is warranted by the clinical course, because most of this does not require any treatment and does not require any testing. Please remember, we are talking about gastroesophageal reflux, non-complicated. And there are many problems with current therapies. The relative lack of response to acid suppression of some groups of patients, including irritable infants, infants and children with extra esophageal symptoms, prompted are really important and should be considered. They usually do not require any treatment. But let me comment now on some of the major recommendations. Acid suppression therapy. The recommendations say limit acid suppression therapy of patients with typical reflux symptoms with gastroesophageal reflux disease, and limit it to 4 to 8 weeks, but don't use it. Don't use it for regurgitation only, because then regurgitation only usually does not require any treatment unless you made the diagnosis of the disease. And this is really an important statement, because we know that acid suppression therapy may be associated with an increased risk of respiratory tract infections and gastrointestinal tract infections. Assessment of efficacy and investigations, if treatment is evident, is appropriate at that time, and avoid use of acid suppression for cough, for wheezing, or asthma in the absence of typical reflux symptoms. So again, gastroesophageal reflux is not the same as a gastroesophageal reflux disease, and therefore for the disease, we do need treatment like acid suppression therapy for limited time, but for uncomplicated reflux, we don't need it. I also would like to comment on hypoallergenic formula or maternal elimination diet for breastfed infants, which is now recommended before use of acid suppression. And for positional therapy, I want to comment that it's not recommended according to the recommendation. So my summary number 2 for this part of our presentation is that infant regurgitation is the most common functional gastrointestinal disorder in infants below 12 months of age, and that most infants and children who exhibit symptoms of reflux, such as regurgitation, vomiting, or discomfort, have uncomplicated reflux rather than gastroesophageal reflux disease. And this results in a different approach to the treatment. And I will add here, avoid acid suppression therapy as much as possible, unless you have gastroesophageal reflux disease. Okay.
Now we are ready to move to the second disorder, that is infant rumination syndrome. And in this disorder, there should be all of the following for at least 3 months: repetitive contractions of the abdominal muscles, diaphragm, and the tongue, feeling that is very bad, associated with regurg of gastric content into the mouth, and whether he is going to expel this content or re-chewed and re-swallow it again. These two things can happen in the same patient or one of them. 3 or more of the following should be fulfilled as well. Onset should be between the age of 3 and 8 months. One of the features, it does not respond to management of gastroesophageal reflux disease or regurgitation. It's not accompanied by signs of distress, and it does not occur during sleep and when the infant is interacting with individuals in the environment. Who remembers such a case in his practice?
Well, I think it's a good question to the audience. Yes. It's not so common in our setting, and also the data on it are quite limited when it comes to the management. So I don't know what is your experience in your country, but in our country, it's not that common. When it comes to the management, as I already shared, there are, generally speaking, limited data. Malnutrition is one of the major concerns, and this is because previously swallowed food is repeatedly and excessively lost. And frankly speaking, the management aims at eliminating the need for ruminative behavior in order to improve the infant's nutritional status. However, as I said, it's not very common in our setting.
What about the summary?
Okay, good that you came back. Data regarding rumination syndrome in infants and toddlers are still limited. Malnutrition may be the problem.
You know, Professor Hania, I'm sorry to interfere with this. In Egypt, I think the re-swallowing of the food is something that is shameful, and sometimes mothers does not mention this while they are mentioning it is a case of vomiting or regurgitation or GERD or something like that.
So in your opinion, it's quite common in Egyptian children?
Not that common, but it is more common than now appreciated.
Okay, thanks a lot.
And then we can move to the third category, which is cyclic vomiting syndrome. And in cyclic vomiting syndrome, all the following should be fulfilled: 2 or more periods of unremitting paroxysmal vomiting with or without retching, lasting hours to days within a 6-month period. It may be severe nausea as well. Episodes are stereotypic in each patient. Episodes are separated by weeks or months with return to baseline health, not to health baseline, his baseline status, between episodes of vomiting. And look at this case scenario with me. Ali, a 3-year-old child who had had severe vomiting with and without eating, little abdominal pain. He had such attacks 6 times in last year. He was admitted to hospital in 4 of them for medications and intravenous fluids. Attacks lasted between 3 and 7 days. The mother said, "They told me in the first 3 attacks it is acute gastroenteritis," but she wondered. There was no diarrhea all through these attacks. Do you feel familiar with this presentation? If you feel it, this is a case of cyclic vomiting syndrome. Professor Hania?
Yeah, and I think that many physicians every now and then see the patients like that, even if, and I will talk about it in a moment, the differential diagnosis is really quite extensive and a number of diseases has to be taken into account. If you look at the data, and this comes from a very recent review paper by our colleague who are really experienced with this condition, you will see the data are quite limited and the prevalence is about 2%. You will see what is the age of at onset. It's about 3.5 to 7 years. Gender, it's more or less the same with slightly more females than males ratio. Mean time to diagnosis, 2.6 years. It's a really long time. And this is a huge, I mean, you will see an extensive differential diagnosis, as you will see in a moment. Episodes per year, 3 to 12. Duration of attacks, if it's only 2 hours, then you can really make problems with the diagnosis. If it lasts for a very long time, that is probably easier. But generally what I would like to show and how to summarize these slides, that really data are quite limited.
What are the other differential diagnoses of this disorder?
Okay, as I mentioned already before, there is a number of diseases, surgical and non-surgical, which should be taken into the account. And you mentioned in your case that, for example, acute gastroenteritis was considered to be the cause of some symptoms that your patient experienced. So if you look for non-surgical, we just give you some of the gastrointestinal, gastroesophageal reflux disease that we already mentioned, peptic disorders, inflammatory bowel disease, intestinal pseudoobstruction, chronic appendicitis, hepatobiliary disease, almost everything that you can find in the textbook of gastrointestinal gastroenterology, you will find it. But also metabolic diseases, endocrine diseases, nephrologic, neurological. So a long list. That's why it makes it that we can summarize that many gastrointestinal and extraintestinal disorders come into differential diagnosis with pediatric CVS, cyclic vomiting syndrome. And one has to think about it when you see the child with episodes of vomiting. But I know that you have large experience with the management of cyclic vomiting syndrome. So please comment on the prevention and treatment of CVS and also from your perspective as a pediatric gastroenterologist in Egypt.
Okay, myself and my team, Professor Ahmed Hamdi, head of the pediatric gastroenterology, and the rest of the team, in the last 10 years, we found in the database 112 patients with cyclic vomiting. And actually, their distribution was functional cyclic vomiting syndrome in 92 cases, and surgical conditions were discovered in 10 of them, metabolic disorders were found in 5, and neurologic abnormalities in 5 of them. And here you can see the difference according to age, whether they are toddlers till the age of 3 years or children later. And you can find that the functional disorder, which is cyclic vomiting syndrome, was the most predominant category. But you can find surgical and the metabolic more in the younger age compared to the older age. But neurologic may be slightly higher in the older age than the younger age, to the extent that we can say, when you face a patient below the age of 2 years, think think surgical and metabolic first before giving the criteria its place. And in cases with children and adolescents, you may think in a neurological abnormalities first. And prognosis is favorable. Ondansetron with intravenous fluids in the acute event is usually helpful. It may take 2 to 3 days to abort the attack. Propranolol or cyproheptadine as controllers, although in the literature cyproheptadine was given first before propranolol. In my experience, propranolol is working adequately without the problems of cyproheptadine. An average duration on controller was about 14 months. 102 cases had positive family history of migraine in parents or grandparents. 23 developed migraine for the time being. Yes.
Yeah, I will just comment. I will come back to the review article, which was published very recently. And as you can see, there is a number of other drugs which are used also for prophylactic, supportive, and during acute phases. I will not go into the details. I just want to summarize. There are two aspects: prevention of episode, reduction of the severity of the attacks, and what is important, that is for all therapeutic recommendations, all therapeutic recommendations are made for off-label use. Is it the same in Egypt or it's different in Egypt? In Europe, it's always off-label use.
All of them are off-label use in this disease.
Yeah, so it's important also to keep this in mind. And this is because there are not too many studies which really well randomized, double-blind, placebo-controlled studies which are evaluating this particular situation.
Which options are considered the most effective for the management of CVS?
Okay, so again, if you look at the literature, you will see that the most effective strategies are those which you can see on this slide. One is the use of antiemetic and sedative, and it is ondansetron and lorazepam. And the other very effective is chlorpromazine and diphenhydramine. Those are considered the two most effective strategies, always two of those drugs.
Ondansetron is also used in other pediatric conditions, such as acute gastroenteritis. Do you want to comment on this as well?
That's very much true. And I had the privilege only a week ago to participate in the similar webinar. And I was talking about acute gastroenteritis and vomiting during acute gastroenteritis. And the question asked was to use or not to use antiemetics. And I just want to repeat again that when it comes to acute gastroenteritis, ondansetron, which is selective 5-HT3 receptor antagonist, which blocks serotonins both peripherally and centrally, is commonly used in pediatric hemato-oncology, but it's also used as an antiemetic for acute gastroenteritis. So not only cyclic vomiting syndrome, the one that we are discussing here, but also I had the privilege to discuss it, the use of ondansetron in this webinar a week ago as an antiemetic, the only one which is recommendations for acute gastroenteritis. So my summary number 4 for this part of our presentation would be that for the pediatricians, the major aim is to have early clinical suspicion to avoid diagnostic delay and start adequate phase-related symptom-tailored management when it comes to cyclic vomiting syndrome. And we already discussed what is a treatment and what is a prevention.
Now we can move to the 4th category, which is infant colic. Who can define infant colic is a problem, although it is common, but it is a true problem.
Excellent question. Excellent question, but because what really is infantile colic? We are saying it's an excessive crying, fussing in an otherwise healthy and thriving infant. But the problem is that very few people agree as to how much crying is considered excessive. What will be excessive for me, for someone else, maybe absolutely normal. And there is recent, maybe not recent, but a few years ago, there was a study published by our colleagues in Journal of Pediatric Gastroenterology and Nutrition, and they looked at 39 trials on infant E. coli. And the authors in clinical trials used 20 different definitions, which shows how difficult it is to compare one study with another study. And that's why it's so important to look at the criteria. And I will not go into too many details. I just want to tell you that according to Rome 4 criteria, you have criteria for clinical purposes and you have criteria for clinical research purposes. Much more strict criteria are for research purposes. For clinical purposes, an infant who is less than 5 months of age when the symptoms start and stop, recurrent and prolonged periods of infant crying, fussing, or irritability reported by caregivers, and no evidence of infant failure to thrive, fever, or illness. Look here, there is nothing like 3 hours per day, 3 or more days, etc. Something that we have for research purposes. Because if you have a child who is crying for 2.5 hours, does it mean that this child doesn't have, and only for 2.5 days, does it mean that this child does not have infantile colic? Of course it has. But this research, clinical research purposes are important when we want to compare one study with another study. I already showed you how many different definitions are used in clinical trials. So for scientific purposes, we need very strict definition. For clinical purposes, the definition is much more flexible, and this is really important. And what I would like to stress that infantile colic is considered benign, but may be a source of concern and frustration. And look at this impact of infantile colic. This is a summary of a number of studies showing short-term association and medium to long-term outcomes. And short-term associations are quite well documented. Medium to long-term are not so well documented. There's a discussion in the literature. Short-term associations, maternal depression, child abuse, early breastfeeding cessation. And I want to call your attention to child abuse. If you look at the data on the impact of colic or child abuse, you will see that the colic is the strongest risk factor for shaken baby syndrome. So we are considering it benign, but it may be really frustrating and may have some health consequences. On this slide and on the next slide, I would like to show you summary of evidence from randomized controlled trial for the management of infantile colic. The first which I would like to discuss is the use of probiotics, and our team contributed with a number of studies and also meta-analysis. And the probiotic with proven efficacy is Lactobacillus reuteri, DSM 17938. All these letters and numbers are important. And it's particularly effective in breastfed infants. However, we can discuss whether there's any difference between breastfed and formula-fed infants when it comes to colic. Possibly effective, a number of interventions: hydrolysed formula, hypoallergenic diet in breastfeeding mothers, reduced stimulation, improved parental responsiveness, focused parental counseling, acupuncture, only possibly effective. What else do we have? We have a number of interventions which are considered ineffective. I don't know how it is in Egypt, but in Europe, in many countries, Simeticon is often used, but it is ineffective. Spinal manipulation, lactase, soy formula, all of those are considered ineffective. There are some interventions which are very effective, but possibly harmful. Dicyclomine, cimetropin, these are very effective, but because of the side effects, they should not be used. Effective but short-lived effects is the sucrose. So I showed you what is the literature says, but now I have a question to you. What is an Egyptian experience with infantile colic?
Thank you. How much common regarding the infant colic at the age of 2 months, and the problem of differentiation between significant and insignificant colic is usually a problem, and quantification or scoring system that can classify them are very tedious. However, in our experience, and you can wonder, Professor Hania, that we found that the most significant, who are very difficult to soothe or quieten, and the role of grandmother here is very important. And those who are very severe will not even be soothed by the grandmothers, and those who are insignificant will be soothed by anyone else. So you can find here that the sector for significant infant colic is a small section, but majority are having insignificant, and the majorities are not having colic at all. The problem is
I
that
like to comment about the grandmothers. The
Yes.
grandmothers are never considered in a randomized controlled trials.
Yes, we can do it together. We can do this research because grandmother are very helpful in this issue, and their effect is magic. So I want to add here that among the significant forms, my message to the physicians and pediatricians is that some of the organic diseases may be mixed with the infant colic, that is a functional GI disorder. And sometimes a underlying neurologic problem may be there, or sometimes there may be a surgical condition underlying. So please, before considering it as a functional GI disorder called infant colic with its criteria, get sure there is nothing else in the clinical examination and your assessment. And in my experience, Professor Hania, I found that those are having feasting of one side, not the other, at that very young age. This is usual sign of lateralization, and in many cases were diagnosed as subdural hemorrhages due to shaken baby syndrome on top of an infant colic. So it was a mild form, and they shaked it, and they produced an intracranial hemorrhage that made the problem very significant and not responding to any reassurance or anything else. So think in this. And if there is bleeding or something else like diarrhea, like severe vomiting, take it seriously and do not diagnose it as just the functional infant colic. Now, what's your opinion about the prevalence of this problem, Professor Hania?
Okay, that's an excellent question. I will go to the slide, which now I don't have it here, but I already showed you the slide with that it's about 20%. And the problem with the data is that we are using, and I showed you already in this previous studies, that there were so many different definitions that you can find when it comes to the prevalence in the literature, whatever percentage you want. But on average, I would say it's about 20%. And I want to come back to the grandmothers. They are very good in Egypt, but they're also not very bad in Poland and probably in many other countries. Sometimes they do there are some problematic, but very often they are really very helpful.
Yes, yes. So do you think formula feeding has got something to do with infant colic in your practice?
It's a very good question, which is very often asked. And let me talk a little bit about it, because when you look at the pathomechanism of infantile colic, and of course, we don't know what was the mechanism. If we knew, that would be much easier. But one of the mechanisms, which is, or one of the causes of the infantile colic, which is often considered in the literature, is cow's milk allergy. And this is very, I would say, very politically incorrect cover. Politically incorrect because we have a baby which is fed with bottle, but some infants are bottle fed with infant formula. And then the question question is, could this be the cause of infantile colic? And as a matter of fact, if you look at the literature, you will see that a subgroup of infants with colic may have an allergy or intolerance to cow's milk. And if yes, infants with allergy or intolerance usually have associated clinical features such as bloody stool, vomiting, rash, etc. And there are some consequences of that, because then we are thinking whether or not to use hydrolyzed formula. And I showed you previously that hydrolyzed formula is considered to be effective in some of the reports. But if you look at the very recent Cochrane review on dietary modifications for infantile colic, that you will see that the conclusion was that benefits reported for hydrolyzed formula were inconsistent. And then if you look at the data, I already showed it's the recommendations, and I already showed you one, you will see that there are some discrepancy. The Cochrane review says the data are not so convincing, but in other reports, you will see a one-week trial of extensively hydrolyzed formula is an option for formula-fed infants with colic who have not responded to first-line interventions. And extensively hydrolyzed formula may be continued if there is a decrease in crying or fussiness. The response usually occurs within 48 hours. If not, that doesn't make any sense to continue. And the original formula is resumed if there is no change to the infant's symptoms. Because one of the reasons is that hydrolyzed formulas are more expensive than cow's milk-based formulas, at least in Europe. Maybe in Egypt, it's slightly different.
So, do you think the prematures are more liable for infant colic?
Again, this is a question which is very often asked. If you look at the data, you will see that the incidence of colic does not appear to differ among males and females, breastfed and formula-fed infants, or full-term and preterm infants. So answering your questions, it seems, based on the data, that there is no major difference.
Is gender a risk factor for infant colic, so that it's more in males?
I already answered you that there is data show that female girls and boys, it's probably very similar prevalence of infantile colic.
Yeah.
And my question to you would be, what would be your answer to those questions in your experience? And additionally, do you think that family distress is related to infant colic?
Okay. This is a study called ACT study, in which knowledge, attitudes, and the practices of pediatricians on infant colic in the Middle East and North Africa region were assessed. And 37% of enrolled pediatricians stated that formula feeding was the most important risk factor for infant colic. This is the belief of the pediatricians in our region. And almost 30% of them indicated that prematurity is a major determinant factor. Again, they found that the male gender was a more risk factor. And my explanation here for this male gender presenting in the clinics for my dear pediatricians is that in Egypt, they have a masculinizing thinking in which they present male patients more than female patients, so that this may lead to male preponderance in this category. 6% believe that firstborn was a risk factor. And in my opinion, this is a little bit correct because of lack of previous experience in dealing with the children. And 4% found that family distress is a risk factor. And in my opinion, this is true to a little extent, but it may be a result more than a cause in this condition. Same results were reported from Algeria. Yeah. Okay.
Do you want to finalize with a previous slide? No.
Yes, this is finished.
Okay.
Yeah.
Then the question is, what are the most common symptoms associated with infantile colic? And I know that I know that you know the answer to it.
Yeah, the most common symptoms associated with were abdominal distension in this study, sleeping deprivation or disorders, feeding disorders, or abnormal stool consistency as well. Then the question is, are we going to diagnose on clinical, laboratory, or radiological basis? And in fact, our physicians usually think that they can diagnose on a clinical ground, and only minority of the physicians will need some investigations, especially in special conditions, like having bleeding in the stool or massive abdominal distension. Yes?
So it's a good news. It's a good news that people are not doing too many testing, because it's not really necessary for infantile colic. And let me summarize with this. Infantile colic is considered benign, but may be a source of concern and frustration. But generally, it's a benign condition. And this is important for our discussion. Okay.
Now we are moving to the first category, which is functional diarrhea. And actually, the Studler's diarrhea or functional diarrhea should fulfill all the following. It should be daily, painless, recurrent passage of 4 or more large unformed stool. Symptoms last more than 4 weeks. Onset between the age of 6 months and 60 months of age. No failure to thrive provided caloric intake is adequate. When we should proceed for investigations in such cases, do you think this is common in your practice?
Okay,
Professor?
so yeah, oops.
Yeah.
Let me try to answer your questions. And the questions for this, I go again to the literature. And if you look at the functional diarrhea meeting Rome's 3 criteria, so this is this earlier study in Journal of Pediatrics, it's about 2.4% in infants below 1 year of age, and 1 to 3 years of age, about 6.4%. And then when it's reported by mother, it's slightly different. It shows again how important it is that we follow the criteria when we are making any kind of that diagnosis of functional gastrointestinal disorders.
Mothers will ask you, Professor Hania, for a treatment of this diarrhea. What do you recommend?
Okay. And then it's a very easy answer. And this is one of these conditions that we like to see, because no medical intervention is needed. It's just education and reassurance. Sometimes dietary changes are needed, like to evaluate fruit juices if there is no overconsumption of fruit juice and fructose intake. But usually this is something that resolves by 60 months of age, 5 years of age. And what is important for functional diarrhea, and it may differentiate from diarrhea with organic causes, that if you look at the growth curve, there is no failure to thrive. Those are very well growing children. So this is important. Then you don't have to worry. And it's easy to explain to parents, to show on the growth charts, everything is okay. Just tell what are the symptoms or signs that you have to worry, like, for example, blood in the stool or growth failure, etc. Then it's something to consider for the management. So my summary number 6 for this part of the presentation is functional diarrhea is not harmful and is indeed self-limiting.
Okay, coming to the 6th category, which is infant dyschezia. And
again,
yeah, we must include both of the following in an infant less than 9 months of age. At least 10 minutes of straining and crying before successful or unsuccessful passage of soft stool. No other health problems. And do you think this is common in your practice? Professor Hania, please.
Okay, I think we do see it in our practice, and I was surprised, as a matter of fact, 2.4%. My perception was that we see it more often. I don't have data from my country, but I think that it's as what it comes to our department. But the data are showing about 2.4%. It's definitely not one of those most common functional gastrointestinal disorders, because again, the most common are regurgitation, colic, and constipation. And dyschezia is not the same as functional constipation, as we will explain in a moment.
Yeah.
For infant dyschezia, it's again important to look what are the criteria, and according to Rome 4 criteria, to make the diagnosis, it must include in an infant below 9 months of age, at least 10 minutes of straining and crying for successful or unsuccessful passage of stools, and as you said a few minutes ago, no other health problems. And for pathophysiology, it's usually uncoordinated defecation dynamics. So it is something that it's not worrying us very much. And I think we already discussed it. So for infant dyschezia, management, education and reassurance, avoidance of anal stimulations and laxative. And when it comes to outcome, it usually resolves by 9 months of age, according to the definition. So let us summarize it by saying functional dyschezia resolves spontaneously, though effective reassurance is the key importance in the management of this condition.
Okay, can I comment here? And I agree with you that this number 2.4 is less than actual, but most of these cases may be diagnosed as constipation wrongly by parents and not reported as dyschezia. This is maybe the cause why the number is less than our expectations. And now we are moving to functional constipation. And here, according to Rome criteria, we should have 1 month of at least 2 of the following in infants up to the age of 4 years. 2 or fewer defecations per week, excessive stool retention, painful or hard bowel movements, large diameter stool, large fecal mass in the rectum, and in toilet trained, we have another 2 things. At least 1 episode per week of incontinence after the acquisition of toileting skills, or a large fecal mass in the rectum that is clogging the toilets maybe. And do you think this is common in your practice?
Well, the answer is very simple. It's really very common. And as you know, it's about 3% of visits to pediatric outpatient and 25% of pediatric gastroenterology consultations, probably even more. Sometimes I have a feeling that it's about 50%. So functional constipation is quite common. If you look, however, at the prevalence of functional defecation disorders in children, and this is quite recent paper published in Journal of Pediatrics from Mark Beninga from a team from the Netherlands, you will see a pooled prevalence 9.5%, but look at the ranges. It ranges from 0.5% to 32%. Again, it very much depends on the criteria, which criteria and how strict you are when it comes to criteria. And again, I'm repeating why it's so important to have all these Rome 3, Rome 4 criteria for scientific, for research purposes, because then we can compare one study with another study. But generally, I would say this is quite common. And what is important when we are talking about constipation is you provided the definition, but what are the alarm signs and symptoms in constipation, like red flags, that we will differentiate that it's probably not just a functional disorder, there's organic disorder. Constipation starting extremely early in life, below 1 month of age, because we are thinking about Hirschsprung disease. passage of meconium, again, after 48 hours, it will be again Hirschsprung disease, family history of Hirschsprung, ribbon stools, blood in the stools in the absence of anal fissure, failure to strive, always when there's a failure to strive, something is wrong. Fever, bilious vomiting, abnormal thyroid gland. So there's a number of these red flags, alarm signs, which are important just to make, to think it's not a functional constipation. It may be some organic disease. And
lines. Then what are the lines of treatment for functional constipation in your opinion and in the literature?
Well, again, I will go to the guidelines of my favorite society, ESPGHAN, European Society for Pediatric Gastroenterology, Pathology and Nutrition, and our North American colleagues, NASPGHAN. Quite old recommendation, 2014. So it's really time to update them. And there is some new data, but I will tell you what is in the guidelines. So when it comes to the management, what is recommended and what is not recommended. Recommended, look, normal fiber intake, normal fluid intake, normal physical activity. It doesn't say it has to be more than usually, but just to make sure that there is at least normal fiber intake, normal fluid intake. Very often it's really below. So you don't have to give more, but at least what should be given according to the age. Demystification, explanation, and guidance for toilet training in children with a development age at least 4 years. And for pharmacotherapy at the moment, what is macrogols, polyethyl glycol, or lactulose if PEG is not available. So this is recommended, but what is not recommended? Probiotics, prebiotics. A lot of studies, I would say, but none of the probiotics and none of the prebiotics has been consistently shown to be effective. Intensive behavioral therapy, biofeedback, it's not recommended. Alternative treatments, not recommended. And routine use of multidisciplinary treatment is not recommended. So the guidelines are saying what is recommended, what is not recommended. Let me very briefly look at the pharmacotherapy. Extremely important is disinfection. This is that you have to make it absolutely clear that you start with fecal disinfection. And you can use either polyethyl glycol or enema, and afterwards you will start with a maintenance treatment. And the maintenance treatment should continue for at least 2 months. One of the mistakes which is often made, it stops, the dose may be too small or the duration of treatment may be too short. All symptoms of constipation should be resolved for at least 1 month before discontinuation of treatment, and treatment should be decreased gradually. You may use either PEG, polyethylene glycol, macrogols, or lactulose, depends on the country. And allow me just to make one additional comment, because I showed you what are the recommendations. They are already from 2014, but there are also studies looking at the awareness and implementation of these ESPGHAN, NASPGHAN guidelines. And it's something which is really, that is, people unfortunately do not follow these guidelines. Poor familiarity with previous guidelines for functional constipation in children has been described in the literature. Studies on the awareness of the most recent guidelines have, however, not been published, and approximately 1/3 of physicians were unfamiliar with 2014 ESPGHAN-NASPGHAN guideline, and unfamiliarity with the guideline was more common among general pediatricians and amongst physicians from the United States, but we know it applies to other countries as well. A digital rectal examination is often avoided in children, especially by general pediatricians, and prescribed medication for disimpaction and maintenance treatments correlated well with the guidelines for children 1 year of age or older, and to a lesser extent to infants. So my summary number 8 would be for this part of our presentation that for the management of functional constipation, both the disinfection phase and the maintenance phase are important, and polyethylene glycol is the primary medication, and it's important to follow the guidelines. But now I have a question to you. Can you summarize the differences between functional constipation and dyschezia? Because sometimes those two diseases, those two conditions, may be confusing for physicians.
Actually, Hania, this is very common point of confusion in clinical practice, and many cases sent to me as constipation are actually dyschezia, not the reverse. So over-treatment is done here. And if you're having this person with this training, first of all, try to find two criteria of the definition given to the constipation. And in dyschezia, you'll not be able to collect two criteria for the definition of constipation. And my recommendation is look first for the criteria. Are they present or not? And by that time, you can find. Sometimes you ask yourself, they said straining with successful or unsuccessful defecation. This is not delayed defecation. This is unsuccessful after the period of straining, but he can do his motion on daily basis that is not hard stool or painful, and so and so. So taking a good history and the description, and sometimes you can see the pictures of the stool of these patients and videos for these patients as well. You can diagnose the case as dyschezia and avoiding the overdoing with constipation. And I can tell here, Professor Hania, that in our study in school children, we found that constipation this is a study by Professor May Nassar and myself in thousands of school children. We found the prevalence of constipation is 17.4%.
17.4. Okay.
17.4, yes.
Very good. Excellent. Okay, I think that we have covered all of these functional gastrointestinal disorders which occur during infancy and toddlers, and I think it's time for take-home messages. Allow me to start with my take-home message. And as a take-home message, I really like to show this slide. I often show it to our medical students. I often show it to our residents. We showed you the guidelines, we showed you the evidence, but even if the best evidence guidelines are available, they do not automatically lead to improved health outcomes. And there are many barriers between evidence and clinical outcome. And these barriers extend from awareness to adherence. And there is a role for physician. Physician has to be aware of the evidence, of the guidelines. I provided you the example of NASPGHAN, ESPGHAN guidelines of functional constipation. They are published, but people are not following it. So they should be aware of the guidelines, of the evidence. The evidence, the guidelines has to be accepted. It should be applicable. Physicians should be able and act on the guidelines, on the evidence. And there is also a role for patients. Patients have to agree with the guidelines. And last but not least, they have to adhere to. I don't know how it is in Egypt, but in many European countries, the patients, the parents, they immediately go to Dr. Google and they try to find whether or not you are right. And it's probably true also from countries. So again, even if the best evidence-based guidelines are available, they do not automatically lead to improved health outcomes. And it's important to remember it. So now, Professor Mustafa, it's time for you.
This is my take-home messages. Although infections and dietary malpractice are common causes of GI disorders in Egyptian infants and toddlers, still functional GI disorders are more common and should be kept in mind. Observe red flags, not only at the start of the diagnosis, but all through the follow-up period till the manifestations disappear. I think cost-wise, we can save 60 to 70% of the expenses of pediatric GI diseases if we followed the guidelines.
So these were our take-home messages, and we thank you very much for your attention.
Thank you.
And I thank you, Professor Mostafa, for this dialogue with me. Thanks a lot. Thank you very much.
Yes, thank you very much, Professor Hania, Professor Mustafa. Thank you not only from me, but from all pediatricians over the world. They have thousands of pediatricians seeing you. Yeah, thousands from Middle East, from Saudi Arabia, from Emirates, United Arab Emirates, from Kuwait, from Oman, from Iraq, from Lebanon, from from Oman, and from USA, and from England. Yeah, thousands seeing you this marvelous panel discussion. Yeah, and from Italy also. Yeah, yes. We have a lot of questions. Let's start with a question.
Yes.
Yes. Yes.
Yes.
Yes.
Special.
Yes.
Yeah, there is a special thanks from most of pediatricians, especially professor in Egypt, Dr. Mustafa. Huh?
Thank you.
First, thanks Professor Hania and Professor Mustafa for the excellent. This is from Iraq, Dr. Khalaf Gargari. Do you think overuse and overdiagnosis of GERD and the consequent overuse of BBI lead to intestinal dysbiosis, in turn lead to FGID?
Can I comment on it? It's an important question, and I think that I did try to cover very briefly in my presentation. There is a huge problem with overuse of PPIs in many countries, definitely in European, definitely the United States. I'm sure the Professor Mustafa will comment in a moment how it is in Egypt. And there are really consequences of that. And the consequences are that there is a risk of infections, gastrointestinal infections, respiratory tract infections, but there are also links between the use not only of PPI, antibiotics and PPI, and later on about the risk of allergy and obesity. Here we are speaking about associations, links. We are not talking about the causation. But yes, there are some consequences of overuse of PPI. So this is comment from myself, and I'm sure Professor Mustafa will talk about how it looks in Egypt.
Yeah. I agree with you, Professor Hania, that PPIs should be prescribed cautiously and according to the guidelines. And again, I respect the guidelines of ESPGHAN and NASPGHAN that recommended a trial of elimination of below 2 years in patients having GERD manifestations regarding cow's milk products and maybe the eggs as well before starting the medicinal therapy of gastroesophageal reflux disease. Although this sector represents only a quarter of the patients, but they took this recommendation based on the idea that BPIs are not the beloved drugs that should be used cautiously with their side effects. And in my study, I showed that many of these persons will have small bowel bacterial overgrowth as a long-term consequence of use of proton pump inhibitors as well later in their life.
Yes, okay. Any rule of dietary manipulation in treating FGID, Professor Hania?
Say again, sorry?
Any rule of dietary manipulation in treating FGID?
Well, it depends very much, of course, which condition you are discussing, but I showed in my presentation that hydrolysed formula are sometimes to be considered in gastroesophageal reflux without any complication because the symptoms may overlap with cow's milk allergy. So sometimes you just want to make it sure. So then there is a short time of trial and you can check it. With infantile colic, I already commented that the data are not consistent. Recent Cochrane review concluded that the data are not sufficiently strong to routinely recommend it. However, in many guidelines, you still see that there is this trial of hydrolysed formula. So it's very much, yes, there are some conditions in which dietary manipulation, I'm just only talking about the elimination, may be effective.
Professor?
May I add here, Professor Hania, why there was a difference in the studies regarding the cow's milk problem and the infant colic. I think in one of our studies in a master thesis, we found that cow's milk allergy will be present in those with significant infant colic only. So the percent is high in significant pathology, but in mild forms, it's very trivial percent, not more than 1% or 2%, which is similar to the normal population, not more. So I think we can consider only cow's milk protein allergy as a cause of infant colic when this colic is very intractable and severe.
Only in a subset, definitely. I showed you there's when it comes to the pathophysiology, there's a number of conditions being, or reasons, causes being, and cow's milk allergy may be one of them. Definitely not in all of the children, that's for sure. So thanks for the comment.
I think we have more than 100 questions. We need to go fast, yeah? Professor Hania, any rule of biofeedback and the probiotic in treating FGID?
Okay, I commented when it comes, I will start with probiotics, which are so close to my heart. So definitely when it comes to infantile colic, Lactobacillus reuteri DSM 1793, and it's quite well documented, meta-analysis, etc., and randomized control trial, mainly in breastfed infants. But then the question is there any difference? Is there any reason to think that formula-fed infants would react differently? And I showed you that the prevalence is very similar. And I would say this is probably the only functional gastrointestinal disorder which is so well documented. We did not discuss functional abdominal pain, but there are some studies for some of the probiotics that may be also considered. For constipation, I would say that at the moment we do not have any of the probiotics that we can routinely recommend. Biofeedback, perhaps Professor Mostafa want to comment, but there is no role at the moment.
Again, for this biofeedback, in fact, my experience is that I send persons for anorectal manometry, and biofeedback may be used in those cases who are intractable constipation. And actually, my study published in a Journal of Pediatric Allergy and Immunology, 2009, was about cow's milk allergy in intractable constipation. And my message here is that many of our colleagues usually proceed with cow's milk elimination in constipation, but the study of Iacono in Italy and ours only assessed the intractable form of constipation that was not responding. A sector of this intractable will be allergic, and elimination of the milk and dairy products will help. And if it is not helpful, biofeedback may help, especially if it is associated with retentive fecal incontinence. And I have some experience with botulinum toxin injection in over 100 cases, and it showed a good response in those who are not responding whatsoever, even to stimulant laxatives.
Okay. Professor Mustafa, this is Su'al from Oman. What is the most effective treatment for a child with cyclic vomiting syndrome?
I will repeat what we said in the slides, that during the attack, when there is an attack, we usually resort to ondansetron injection. And in many cases, it will abort the attack without going to the hospital. In some cases, we need admission and intravenous fluids with NPO, nothing bare os. And after finishing aborting the attack, usually we maintain him on propranolol or cyproheptadine. I usually start with propranolol because cyproheptadine syrup is not available and is not recommended in the young age. I don't like it before the age of 6 years age. So usually we resort to propranolol, and the response is usually very good in these cases, but unfortunately, a large percent of them will recover from cyclic vomiting syndrome to suffer migraine later in life.
Yes, Professor Hania, positional therapy is not recommended in infant, but it is effective in children, right? Positional
Well,
therapy is not
yes.
recommended in infant, but it is effective in children, right?
I see the question, but I do not really understand to which, I presume it's about infantile colic,
Yes.
I think. No, gastroesophageal reflux.
Yes. Good.
Yeah,
Yes.
the data are showing it's not really helpful. So this is all I can say. This is what the guidelines are saying based on the evidence.
Professor Mustafa, regarding rumination syndrome, doctor
Yes.
from Iraq, Dr. Khalaf, say, I have seen 3 cases only in my practice during the last 30 years. What about you?
Actually, because I am a referral location, I see more cases of rumination. But I think those cases diagnosed as gastroesophageal reflux disease who are not responding to treatment before sending them to surgery, please take history, very meticulous history about rechewing of the material in the mouth. And you will find that some of these persons are actually true cases of rumination syndrome. It's not very common, it's an uncommon situation, but these persons, when sent to surgery, they come back with the same manifestations. So before sending this catastrophic situation and passing this problem to the surgeon, first analyze it. You may need with you a psychiatrist, behavioral therapist, and many other helpful conditions. Gastric electric stimulation may be of help. It's not available in Egypt. I have some persons having this apparatus, but actually it's not very prevailing.
And a question from a young pediatrician, why malnutrition can cause a rumination? Professor Mustafa?
I think that I covered it in my presentation, that malnutrition is really one of the major concerns, and the reason is that previously swallowed food is repeatedly and excessively lost. So that's why it can lead to malnutrition, or this is a mechanism.
Yeah.
So the malnutrition is a result of rumination. And the question whether malnutrition can lead to rumination, no, there is no relation here.
What is called abdominal epilepsy can mimic cyclic vomiting? From a young pediatrician also. Huh? Professor Mustafa?
You want to answer, Hania?
No, but I did not hear the question, sorry.
What's called abdominal epilepsy can mimic cyclic vomiting?
Oh, I think that Professor Mustafa has more experience with.
Yes.
I was asked this in a lecture before, and it was about abdominal epilepsy. And actually, when they started to speak about abdominal pain disorders, there is no terminology called abdominal epilepsy. It's abdominal migraine. I know many of our colleagues send persons coming with severe abdominal pain on anti-epileptic therapy for more than 1 year and more, and they are not responding altogether. And these cases were something else, and the diagnosis of abdominal epilepsy, you'll see that symptoms of abdominal epilepsy previously thought autonomic temporal lobe epilepsy as a cause of abdominal pain are shared with abdominal migraine. And there is no relation between cyclic vomiting and abdominal pain disorders, because it is a vomiting disorder, whereas migraine is abdominal pain disorder. So if it is predominantly pain, this is abdominal migraine. It is episodic, it is cyclic form, but it is pain disease. Whereas in cyclic vomiting, it is vomiting disease. Sometimes with migraine, you may have some vomiting, and in cyclic vomiting, you may have some pain, but actually the predominant disorder in cyclic vomiting is vomiting, and in abdominal migraine is the abdominal pain itself.
Professor Hania from Iraq, question, how can we differentiate between gastroesophageal reflux and rumination?
I think we can go back to the slides that we showed, but I think it's really important I would recommend to look at the round 4 criteria to take it and to look, because there is no one single sign or symptom. So there's a set off for each one of them. And then to just to understand what are the differences. Professor Mostafa covered the nomination. Of course, I can repeat it, but I don't think that it makes sense at the moment.
Yeah. Professor Mustafa, this question to you: can the dose of ondansetron can be given more than once daily?
It's
in
once.
gastroenteritis or even in other cyclic vomiting?
Actually, in acute gastroenteritis, it's once. You can repeat it for 2 days in cyclic vomiting syndrome while hospitalized, under monitoring for the risk of occurrence of dysrhythmia of the heart.
Yes. Okay. In other diseases, not gastroenteritis?
Once.
Gastroenteritis?
Yeah, it's once. Once dosage. Yes.
Professor Hania, thank you for excellent informative presentation. How long can I use the medical strategies for cyclic vomiting syndrome? Do I need gradual tapering after improvement? Do I need any behavioral modification therapy to minimize the episodes? Yes,
Professor
again.
Mustafa is an expert on cyclic vomiting,
yes.
So I will leave this question to an expert.
Okay. Professor Mustafa, how long can I use medical strategies for cyclic vomiting
I know
syndrome?
there is no recommendation for the duration of use of maintenance therapy, but in my series, stopping the maintenance therapy before 12-month period is usually associated with recurrence, but usually it was 14 months in my series when we stopped and vomiting did not recur again after many years after stopping the medicine. Behavioral therapy sometimes is very important, but what is more important in cyclic vomiting is that the mother can pick up what is the stereotype pattern that provoke the attack. If the mother can discover what can provoke the attack, she can avoid this. For example, some will be provoked by a heavy meal at night, some by recreative long day with cold weather coming back to home, and they start to vomit by the morning, early morning. Sometimes we can delineate the provoking pattern and try to avoid it. This will help a lot.
Okay. Another question from Dr. Bassem Atalla about propranolol in treatment of abdominal migraine. First, what is the maximal duration of treatment? Professor Hania?
Well, we did not cover today migraine. I think that we should stick to those questions that we were discussing.
Yes, there is a lot of questions to Professor Mustafa.
Yeah. But I think that we have to because we should start with a definition, with round 4 criteria, etc. So I think that it's better to just stick to the topics.
Okay. Professor Mustafa?
Do you want an answer?
Yes. First, what is the maximum duration of treatment of propranolol in treatment of abdominal migraine?
Long-term use of propranolol may be associated with some problems of the heart rhythm, and monitoring of the ECG may be needed. And sometimes you give a very short few weeks duration and then you follow up them. You may need to repeat the courses. To the best of my knowledge, there is no maximum time to recommend the maximum duration for use of this prophylaxis for migraine.
What about the relapsing rate? I think it is very high after a stoppage of a drug.
For abdominal migraine?
Yeah.
Yeah. Again, if you are using it for a few weeks, recurrence is usual. And if you are using it for a few months, you may have this a longer distance between the attacks.
Yes. Professor Hania, thank you so much for wonderful presentation. This is Professor Nagi Shouha from Alexandria, Egypt, speaking about gastroesophageal reflux or GERD. Frequent use of thickening or using AR formula. I always wonder, are we using them for the sake of the infant or for the sake of the mother? Thank you.
I like it. I like this comment. Very good comment, Frank.
Yes.
speaking. And let me just comment about the use of so-called anti-regurgitation formulas. It's a long time that the ESPGHAN Committee on Nutrition published its position paper on the use of these so-called anti-regurgitation or anti-reflux formulas. And the only indication for that is when there is a failure to thrive. Otherwise, there are no really good indications. But I really like this comment, using them. Are we using them for the sake of the infants or for the sake of the mother? Well, for GER, and then here we differentiate GER and gastroesophageal reflux disease. Disease means there are some additional symptoms, and failure to thrive is one of those symptoms. And if yes, then this kind of formula may be of some, may bring some benefit.
Yeah. Professor Mustafa, if there is association between infant colic and long-term sleep disorders in older children?
Actually, this was shown by Professor Hania.
I showed it. So there are some data. Yeah, not so strong. I mean, like for example, shaken baby syndrome. It's really quite strong, but for sleeping disorders, it's not very strong. So it's important to make this difference.
Yes, Bifidobacterium animals role in infantile colic.
The new study, published in. There was a randomized double-blind placebo-controlled trial published in Alimentary Pharmacology and Therapeutics, and it's Bifidobacterium animalis subspecies lactis BB12, and it's a randomized double-blind placebo-controlled trial, very similar to the studies with Lactobacillus reuteri. The only, this is one single study, but published recently, so we may say yes, it shows that the microbiota and the whole issue of the using probiotics may be not limited just to one probiotic, maybe some more probiotics, but research is about the repetition of the results, so we need additional study.
There is a political question, Professor Mustafa, which is better, ondansetron injection or oral?
Look, Wael, if you are having the oral form, it usually works exactly like the IV line.
Yeah.
But if you don't have this, you are obliged to use the intravenous route. And in cyclic vomiting, the intravenous route is usually important and is indicated because the nausea associated will prevent this thin film from being put even in the mouth of these kids, because their nausea is very tremendous. You cannot imagine how much they are nauseated and what is their severe vomiting is. And usually we are not able to use the oral form in this position.
Yes. Professor Hania, in cow milk allergy can presented early in the first week of life by colic, for example. This is Professor Sharif Musad from Dubai. Is cow milk protein allergy can be presented early in the first week of life by colic, for example?
Again, we discussed the role of cow's milk allergy in infantile colic. Some children, some infants, it may play a role, but I would not overestimate it. And it's very early in life. Well, I don't think that we do have enough data to say with regard to the age. So no precise answer to the question.
Yeah. Dr. Mustafa?
Yes.
This question to you from Dr. Mustafa Hussein. What about the role of massage therapy with local cream on the abdomen for treatment of infantile colic?
I know this is folk medicine. This is folk medicine.
Yeah.
And folk medicine, everything is available. But is it effective or not? If the grandmother is doing the massage, I think it will work. But if the mother herself with their tense attitude, it will not work. And
if it's done for 4 or 5 months, it goes, it will also.
Yes, and I think we need an evidence for this to recommend it, and we don't have an evidence for it.
Also, Dr. Sharif ask you, is lactobacillus reuteri the only medication for infantile colic for herbal tea when we can use? Is it allows before 6 months of age?
Say again, Lactobacillus reuteri definitely is one of the best studied probiotics when it comes to infantile colic. So it's still we cannot find it in, it does not go into the recommendations, but that definitely there are no ESPGHAN recommendations, but definitely this is 5 or 6 studies, randomized, double-blind, and also individual participant data meta-analysis. Definitely in breastfed infants, whether it's also in formula-fed infants, but I already commented on no difference between the prevalence of infantile colic between breastfed and formula-fed infants.
Another question, what is the impact genetic predisposition on the incidence of FGID and the role of pregnant mother diet in minimizing incidence of FGID?
That's a good question. I'm sure first of all, it's not very well documented, and I don't think that it's one gene that could predispose to it. So not that I'm aware of any of these. The role of pregnant mothers in minimizing the incidence of functional gastrointestinal disorder. Yeah. Again, it is a question, which one do we are discussing? It's about infantile colic. Yes, in some mothers we are using hypoallergenic formula or elimination diet, not formula, elimination diet. So this is probably the only one that we can consider it. And this is also in some of the recommendation. If it helps, then you can continue. If not, no, there is no recommendation to continue with the diet.
Okay, there is a lot of question, repeated question. Dr. Mustafa, diarrhea in well surviving infant below 6 months of age, is it functional? And what is the treatment?
We said that to say it's functional diarrhea, it should be between the age of 6 months and 60 months. And below the age of 6 months, if it is fulfilling the criteria definition of diarrhea, we should search for a cause. For example, there may be infection, maybe allergy, maybe intolerance, maybe anything else. But to define the functional diarrhea, it should be between 6 months and 60 months, 6 months and 5 years. And actually, some mistakes here will happen for the definition of diarrhea, because mothers will come with one motion loose per day and saying he's having diarrhea, and in heavy, busy clinic, we will take the complaint as for granted, and we start investigations, and taking some history will see that this is either a gastrocolic reflex or it is a case of just normal bowel habits without any problem, and reassurance here will be of help, or it is a case of actual diarrhea, whether it is an acute diarrhea or resistant diarrhea or chronic diarrhea, and you are going to search for the cause of it.
Yes.
The fact that it's well-thriving infant is, of course, something which is very important. Well-thriving does not cause such a anxiety.
Okay.
Yes.
What is the age limit for enema in management of functional constipation? Professor Mustafa?
Enema use is usually within 3 to 5 days if you don't have this big polyethylene glycol to evacuate or disimpact the stool. And usually the usual use of the enema is for 3 to 4 days, 5 days, maximum of 6 days. And then we are going to start our maintenance therapy.
For how long we can use lactulose safely?
As long as needed. As long as needed. The problem is with too short use of laxatives, not too long. It may be, I mean, constipation is something that does not occur overnight. So usually the treatment is for weeks, I should say even months, long months. There is no such a thing as a dangers of too long use of laxatives. Again, yes. I would repeat, the common mistake is the dose is too small or the duration of the treatment is not sufficiently long.
Dr. Mustafa, there is a lot of question from Egyptian young pediatrician about the repeated Lancet injection resistant to vomiting.
So if there is resistant vomiting, you should have a cause for this. And if it is going to be treated with antiemetic, usually it is sufficient to give one dose in acute gastroenteritis. And if person is coming to me with persistent vomiting, I'm going to search for a cause of this persistent vomiting more than just giving him repeated doses of antiemetics. Some will ask, is there a role for injectable forms of acid suppressant therapy in this condition? Some will ask this question. And actually, each mechanism is different. When there is a problem in the contractility of the stomach and abdominal muscles, like in vomiting, of gastroenteritis, of cyclic vomiting, here ondansetron will be very greatly helpful. And if it is related to a peptic ulcer disease, vomiting due to peptic ulcer disease, this is something else, it's different. So the problem is lack of differentiation between the cause of vomiting in these conditions.
Yes. There is a lot of repeated questions. Thank you. What about the use of Movicol in constipation, Professor Mustafa? This is from Dr. Osama Hussein.
Movicol is the big polyethylene glycol.
Yeah.
Which was mentioned as #1 medicine by Professor Hania.
Yes. Okay.
Well, it's in the guidelines. Whenever polyethylene glycol is available, macrogols are available, they should be the first line treatment. So in some countries, they are not available. I don't think that there are many countries nowadays. And then lactulose is the first line treatment.
It's sometimes present in Egypt, but not constantly present, so that you, in many times, you will not find Movicol in Egypt.
Professor Hania, rule of goat milk in infantile milk for formula feed baby. Goat milk in infantile colic.
No role.
Is it preferred than cow milk? Yes. Okay. Is there is association between?
May I add something here? Because in certain occasions, they thought that goat milk may replace cow's milk in cow's milk, a protein allergy. And American Academy has stated it frankly that goat milk should be avoided in cases with cow's milk allergy, and the risk of B12 and folic acid deficiency should be considered. I know the formulas that are manufactured are replacing the folic and the B12, the folic, especially folic, but it has nothing to do. It's 92% in similar antigenicity with cow's milk.
Yes, there is a repeated question. I will see this repeated. The first repeated question: do you recommend ondansetron in vomiting cases without diagnose the reason yet?
Acute vomiting, yes. Recurrent episodic vomiting, yes, till you find a cause. But some cases came to me receiving ondansetron at least 3 or 4 injections in a day while they are having intestinal obstruction. Because you know that cyclic vomiting node syndrome, not the functional one, may be a form of repeated volvulus, recurrent volvulus. And with volvulus, it comes with severe vomiting. And just taking a history will elucidate the condition, and you can send the patient for a surgeon instead of giving more dosages with a risk of having side effects.
Yes. Do you recommend ondansetron during vomiting due to infantile colic?
The vomiting associated with it.
Yes. I just asked, this is a repeated question, yeah. Okay.
No. There are many other indications for the use of ondansetron, but infantile colic is not one of them.
Yes, it's not.
Should be stopped. How far vomiting is harmful for children And after how many times we should stop it? This is a repeated question.
I think this question is saying, after how many vomitus I should start acting with medicines or something, antiemetics,
Yes.
for example. You know, those who are having one vomitus or twice with a duration in between may be soothed and it will pass without using this, but repeated vomiting in the same occasion exceeding 3 to 4 times in an hour is a sign that vomiting is significant. And when vomiting is significant, you may think in the antiemetics. But once or twice vomitus, I can pass it, I can reassure the mother, and it will be okay.
Professor Hania, we used to ask the mother to manipulate her diet in the first 3 months after delivery to minimize the infantile colic. Is this widely used practice?
We used to ask the mother to manipulate her diet in the first month.
Yes.
Not as a routine procedure. If you have an infantile colic, a breastfed infant who is infantile colic, you think about a cow's milk allergy, even if it's a breastfed, then you can try it for 1 to 2 weeks elimination diet in the mother. A lot of discussion about that. And if it is helpful, you can continue. But if it's not helpful, doesn't make sense to continue.
Yes. Professor Mustafa, is there any
But
significant...
definitely, I would not. I'm now reading the question. Definitely, I don't think that it should be like it's widely used practice. I would not support it.
Yes. Okay. Professor Mustafa.
But there's also another question: is there any harm if infant colic is not treated? No, there is no any harm if it's not treated.
This is the second. Yes.
Time is a very good physician, probably the best physician.
If there is
the problem is the patience of parents and sometimes of physician goes away too quickly, and that's why we are using a lot of medications.
Yes, is there any relation between infantile colic and the adolescent's IBS?
There are some studies, not very well documented. Generally, functional gastrointestinal disorders, some of them include also IBS. But it's, again, it's all about the associations, links. It's never causation.
Yes. Dr. Hussein Al-Sarafi from Gharbiya, Professor Mustafa, to you, can we use isomil milk in case of hyperammonioma in the first 6 months of life? This is us.
Isomil is a protein, soya, and in hyperammonemia, you are going to avoid protein, whether it is of a vegetable origin, plant origin, or of animal origin. And calculation of the total amount of protein is essential, and I don't have an indication here to use a soya milk below the age of 6 months. I never recommend using a soya milk before the age of 6 months.
Yes. Role of Botox injection in treatment of functional constipation.
I know
yes.
Personal experience, and actually we resort to this in very intractable. You know, Professor Hania, I met a patient who is having a motion every 45 days. And this was a severe form of constipation. He received all his remedies, but in vain. And using these medicines alone may be insufficient. Sometimes we resort to elimination diet. It may succeed, because here testing is not valid, because it is a non-IgE disease. If it's cow's milk induced pathology, it is non-IgE. No test is helpful. So we try elimination. If not sufficient, usually we ask for this biofeedback or a Botox injection. I'm not the one who are doing it. I have a colleague who helps me in this issue, and actually results are promising.
Okay, you see, Professor Hania, there is a lot of question, but there is a repeated. Yes. For how long should we use extensive hydrolyzed formula in suspected cases of allergy, cow milk allergy, before we consider the failure of treatment? That is outside our.
First of all, if you start I think the question is about cow's milk allergy. Again, it's
Yes.
not.
Okay.
It's not
Yes.
regarding to the topics that we are discussing.
Yes, not related. Yeah.
Not really related. So you want me to comment? It's
yes. Okay. Okay. Okay.
So the guidelines are saying that first of all you have to perform challenge to see whether or not it's really cow's milk allergy. But let's say it's a documented cow's milk allergy. So it's about 9 to 12 months, and then you have to re-challenge again, because you should not continue the elimination diet too long. So it's not strictly said, it's about 9 to 12 months.
Yes, we have 112 questions, and I think we covered.
I think Wael, you should you should make a short list, because
yes.
the audience is going to sleep.
Yes, okay.
Now the audience is going to fall asleep.
We come at the end. I just said to you, you are covering all, most of questions. Yes, during your panel discussion.
Yes.
Yeah. Lastly, I'd like to thank both of you, Professor Hania and Professor Mustafa, for highly scientific panel discussion and the clinical dialogue. Thank you very much. If you need to ask Professor Hania about anything, Dr. Mustafa, or Professor Hania, you need to ask also. Discuss with each other any debate.
Answer all the questions.
I want to share with you our experience in infant colic, and something 25 years ago, when we studied the effect of smoking, passive smoking, on infant colic. And actually it works in severe forms of colic, infant colic. When I ask about this habit of smoking and stop it in the near vicinity of the infant, that colic usually improves in many cases. And this was a master thesis 20 years ago, supervised by Professor Hamid Al-Khayyat and myself. And we find that a quantitative assessment of cotinine in the urine of infants is correlated with the severity and time and duration of their infant colic. This is, what's your opinion about this area of passive smoking?
Well, I like the idea. I think that we will find many people who like the idea that it has an impact. Well, if you documented it, it's a probably nice study, nice association. Not studied further, I think.
It helps in some cases.
But now, but now people are more interested in other interventions, and now people are, not so many people are smoking, maybe in your country, yes, but in my country, in Europe generally, it's much more reduced, and I don't think it has any impact on the prevalence of infantile colic. But perhaps this is a good suggestion that we can study it.
Yes.
And find the study. So why not?
Yes. Now we have more than 4,000 attendees on the Facebook Live and Zoom also. Excellent. Yes. Finally, we thank both of you. We thank also Advia Pharmaceutical Company for sponsoring this scientific meeting. And we call for Dr. Maha. Dr. Maha is us.
Well, thank you, Professor Hania. Thank you, Professor Mustafa. It's a very, very fruitful discussion and valuable one for us. I would like to end this discussion that for the above mentioned indications, our company, and we really offer for each indication a proper product for it, such as for colics like spasmo-free, for vomiting, the injectable ondansetron, which is the optimum route, as Dr. Mustafa said, during cyclic vomiting. We have trastuzumab as antidiarrheal. So thank you. We cover all the GIT indications actually actually, and thank you so much for this supportive discussion for us. Thank you.
Thank you Professor Hania. Thank you Dr. Mustafa.
Thank you.
Thank you.
حضرتك محتاج تقول أي رسالة لأي شباب أطباء؟ دكتور مصطفى
ربنا يوفقهم ان شاء الله باذن الله ويشدوا حيلهم وربنا يكرمهم ان شاء الله.
شكرا شكرا. Thank you very much and bye. Thank you.
Thank you.
Thank you.
Bye bye.
Bye.
Bye. Thank you.